Hello and welcome to Heads Up, a year-long mental health awareness journey, Dartmouth Health's webinar series, which focuses on important mental health topics that affect all of us. I'm Audra Burns from Dartmouth Health, and today we are going to discuss substance use disorder and the often inseparable relationship that it has with mental illness and trauma. So we're going to take a look at how New Hampshire's treatment systems are handling the opioid epidemic and how the landscape of substance and patient needs is shifting. So I have three really great panelists joining me today on this topic, starting with Dr. Julia Frew, a psychiatrist and who is certified in addiction medicine at Dartmouth Health and the director of Moms in Recovery program. Hi, Julia.
Hi, thanks for having me.
Thanks for being with us. And we have Laurie Butz-Meyerrose, who is the interim director at the Doorway at Cheshire Medical Center, which is the state's free primary intake program for patients seeking addiction treatment in Cheshire County, which is one of 9 such doorways across the state. Welcome, Laurie.
Thank you. Appreciate you being here. Thank you for having me.
We're so glad you have time for us because I know this is a very crucial topic and you're doing a lot of excellent work out there. So we're going to round out our panel with Annette Escalante, who is the Senior Vice President at the Farnum Center, which also serves as the extended doorway for Manchester After Hours and is the former director of the State Bureau of Drug and Alcohol Services. Welcome, Annette.
Thank you. Great to be here.
So now the goal for this year-long series is to really help change the conversation around mental health to end the stigma associated with it. Now, while society has named substance use as a moral failing, modern clinical science tells us it's far more complicated. So now 10 years into the epidemic of substance use, driven predominantly by opioids like heroin and fentanyl, almost everyone has been touched by this in their personal lives. And we've made significant strides in harm reduction and treatment, but the stigma and barriers to treatment remain. So let me just lead that in with you, Dr. Frew. Let's talk about what are the most common misconceptions regarding substance use disorder and mental health, and what should the general public really know?
Well, as you mentioned earlier, many people tend to think about substance use disorders as if they are simply choices or bad behavior. We really know that substance use disorders are complex neurobiological illnesses, and that it's more common than not for people to struggle both with substance use disorders and mental health conditions at the same time. In other words, it's more the rule than the exception that these two travel together. The other thing that is important to consider is that people who've experienced traumatic life events, particularly early life trauma, something we might call adverse childhood experiences or ACEs, are at much higher risk for developing substance use disorders, as well as developing mental health conditions and even physical health conditions later in their lives. So for example, if someone as a young child has experienced something like the loss of a parent's incarceration, experienced homelessness, or abuse or neglect of any kind, that person is at higher risk as their life goes on, even as an adult, for developing a substance use disorder. Then we know that substance use disorders themselves put people at higher risk to experience ongoing or recurrent trauma. So these are trauma, mental health, and substance use conditions are things that tend to travel together in the same individuals and so benefit from being treated together.
Thank you for that. That's really important background, I think, for people to understand. And Annette, that's a great segue into you. You've observed the local treatment landscape, as a person in recovery, the former head of BDAS, and from, the private sector. So how well is the state of New Hampshire providing for treatment of substance use disorder and co-occurring mental illness?
Well, I just wanted to piggyback off of Dr. Frew's comment. The state has actually done a phenomenal job in being able to provide training for the treatment community on trauma and ACEs, particularly also with social determinants of health, so that people understand why it is that folks end up with having either an SUD or mental health disorder. The current system is divided. And by that, what I mean is that if you are primarily experiencing an SUD incident and are looking for treatment, but may have a mental health condition, that you're going to get treated by one or the other, especially if it's residential. I know that currently, because of the way that the federal dollars come into the state, that's also through SAMHSA, that's also a divided system. And the DHHS is currently looking at being able to address both of these at the same time, but the state of New Hampshire still does not have a co-occurring disorder code under Medicaid. And so you either have to treat one or the other. And I know that they're currently working on hopefully being able to do that. And although there are some programs out there that are stating that they're doing co-occurring disorder treatment, they may likely only have one or two licensed clinicians who can really see the person at one time instead of having the whole facility being trained on co-occurring disorder treatment. And although we're not there yet, we're starting to get there because we're having these conversations and we're bringing other folks that are experts in this field to be able to provide guidance.
Yeah, exactly. And just having these conversations so that people understand the co-occurrence is happening and that they need to be treated together. So let me follow up and ask you this, Annette, then what should patients do to get the best care that they can with the current system that's in place?
So we do have, for example, if folks do not know, they can always call 211 or start with the doorways in order to be able to maneuver which type of treatment that they need. They really need to get an assessment done by a licensed clinician who can determine what the best level of care is. And that may be medical detox, residential, or outpatient services. And that this way they're also able to find out what's actually available in the state. There are some programs out there that will take different types of insurance, and even some who will who are able to do state-funded opportunities for clients who do not have insurance. And then there are respite programs for folks who do not know where they're going to be sleeping for the night, don't have a safe place to stay. And I think that that it's very different for everyone. And so if it's, for example, a family member who is trying to seek or get information, the best route to do it is to call 211 so that they can get connected to their nearest doorway.
And speaking of doorways, I'm so thrilled that we have Laurie with us today to kind of explain what the doorway is for those who don't understand. So Laurie, if you could give a brief introduction to, the doorway system in New Hampshire, where the doorways are located and what they can do for people.
Yeah, absolutely. So the doorways pretty much came into being at the very end of 2018. I believe that they kind of were looking at a program that existed in Vermont called Turning Point, and I think the idea was to try to develop some sort of program that could triage people, assess them, and get them into treatment as quickly as possible. So I mean, that was kind of the basic mission statement. And so there are 9 doorways across the state. Basically, we're 15, Dover Doorway, Lebanon, Laconia, and Androscoggin North. So, and then of course Concord and Nashua and Manchester. The doorways, for the most part, are connected to hospitals. We're connected to Cheshire Medical Center. Dover's connected to Douglas, Laconia region, etc. We typically see patients 16 years or older. So, the idea is that patients will call, sometimes they call 211 to get connected to the nearest doorway. We see them scheduled walk-ins. We also work closely with the hospitals, so we'll get referrals for my primary care, and we will sort of share the hospital duty. We'll go in and see patients, even in the ED. So the whole idea, as I said, is to try to assess a patient. We're licensed mental health. I'm mental health and MLADC. And so we administer what we call a biopsychosocial, an ASAM, which is American Association of Addiction Medicine. And that helps us to kind of level the patient, kind of assess where they are. Do they need medical detox? Do they need residential? Is outpatient sufficient? And when we began the doorway, the idea of getting people into treatment, as I said, was the focus, but then there were all these other kind of subsets that sort of came along. So it was like like Annette said, we've got people who come in with different types of insurance. A lot of them have no insurance at all. So we would try to, get them insurance right away. They had no transportation, they had no insurance, so they couldn't use Medicaid transportation. So we had funding to get people to and from doctor appointments, or to and from the doorway, or from the doorway into treatment. So it was really, Nelson and I both came from the background of residential. So we had we understood what it was like to be on the receiving end. So that gave us a lot of insight on how to get people assessed in treatment. We knew what receiving facilities were looking for because we've been there. So it sort of helped us, to kind of expedite people into treatment. So we've, seen a lot of improvements. I think in 2018, Cheshire County drug death rate was about 4.14 out of 10,000. 2 years later in 2020, it had dropped to 1.8 out of 10,000. So, I think at the time, we had the second lowest rate of in any of the New Hampshire counties. So I think, we see on the average 200 to 300 patients a month. Everywhere, I think we capped out about 260 patients. We have 7 clinicians here. I know we were touching on trauma, and we have 3 clinicians here that are trained in basic EMDR, because we know, the common thread that seems to run through addiction is trauma. So we definitely focus, we make that part of our clinical response to treatment. I think we'd all like to see a little bit more focus on that in residential treatment centers. I know that things are happening, but it is such a significant part of addiction that we make it a focus here at the doorway for sure.
Well, thank you for you and your team's great work over there. And for our viewers, we'll be sure to put a link to the Doorway program in the description of this video so you can find out more information. So Dr. Frew, I want to turn back to you. So tell us about, the special needs of post and prenatal patients struggling with substance use disorder and your work with the Moms in Recovery program.
Yes, so we know that pregnant individuals who are experiencing substance use disorders may face even more barriers than someone who's not pregnant in seeking and accessing treatment. Struggling with substance use in pregnancy is perhaps even more stigmatized than substance use disorders in general. And at the same time, pregnancy is a tremendous window of opportunity for people to access treatment. Often, young pregnant individuals haven't had a lot of contact with the healthcare system. And then when they become pregnant, are engaging in prenatal care, and that may be sort of a way for them to connect with substance use treatment, mental health treatment, overall healthcare. So I run the Moms in Recovery program, which is based at the Dartmouth Health Addiction Treatment Program up here in Lebanon, and we've been around for almost 10 years now. In September, we'll celebrate our 10th anniversary, and we provide integrated substance use, physical health, and mental health treatment for pregnant and parenting individuals with all kinds of substance use disorders, not just opioid use disorders. And we provide that at the outpatient and the intensive outpatient levels of care, so not residential treatment at this point. The program offers group therapy, individual therapy, in fact, using EMDR for some of our folks who've experienced trauma, as well as child-parent psychotherapy, which focuses on parent-child attachment. We also have a women's health provider who can do prenatal care on site, as well as a family medicine doctor who can provide primary care for parents and kids on site, as well as psychiatric care for people's co-occurring psychiatric illnesses. The other thing that we really try to focus on is social determinants of health. So the people that we serve often are experiencing difficulty with housing, with food insecurity, gender-based violence. So we collaborate really closely with a number of community partners to help meet those needs as well. For example, we have a food shelf on site that's provided by the Upper Valley Haven, because we discovered that many of our clients are experiencing food insecurity and have difficulty getting to their local food shelves. So they can use Medicaid transportation to come to a doctor's appointment, but they can't use Medicaid transportation to get to the food shelf. So being able to bring the food shelf to the doctor's appointment has been really helpful for them. Similarly, we have a diaper bank. Diapers are very expensive. And then most recently, we've been able to add a medical legal partnership in partnership with New Hampshire Legal Assistance to help people who are experiencing civil legal needs of various kinds, such as difficulties with housing or with disability benefits. So the goal is to be able to try to, in a very welcoming and trauma-informed environment, meet as many of the needs as we can, all in one place by the same team of providers that people can get to know and trust over time.
It sounds like you have some great community connections up there, which is, I know, helping with the success you're having, not only with the food and the diaper, but like the ease of use for when they come to be able to have the treatment and have the resources. And we'll also link to that information in the description of this video so that our viewers can learn more about it. So Laurie, what are you seeing at the doorway in terms of the kinds of SUD patients are experiencing, and what level of treatment are they needing there?
So we, obviously, opioids is the, primary substance use that, sort of kind of began the doorway, but we've seen a lot of methamphetamine use in the last couple of years. And since COVID happened, we've seen a definite spike in alcohol use disorder. And that's very concerning, especially we've had people that have come in and that have been in recovery from opioids, change, for instance, a year or more, 2 years, even longer, and suddenly now they have an alcohol use disorder. And that's very concerning. I think COVID, was shut down. I'm not surprised that we see this. So one of the things that we do have here that we're very proud of, back at the end of 2019, we started our MAT clinic. So we have a board certified addictionologist here. And we are able to, people can receive treatment here. They can receive their Suboxone. We also inject, we have Vivitrol and Sublocade injections. And one of the things we've started to do, thinking outside the box a little bit, is what we call ambulatory withdrawal. So when people come in here, obviously this is very case by case, because a lot of this is based on whether a person has stable housing, whether a person has a supportive environment. But we can actually have people come in here. We can start them, for instance, with alcohol. We can begin them on a Librium taper, and we have nurses here that can check vitals on a daily basis. It's sort of been one of the greatest ways that I've experienced working in the doorway, is that it's enabled us to really just kind of craft a program that literally meets patients where they are. In other fields, I've been sort of restricted by whatever the program did or whatever funds were available, but we've been able to literally kind of think outside the box and create these programs. And so the MAT clinic has really afforded us that opportunity to do that. So.
That's wonderful. I think some of the best changes and new programs happen when people start thinking outside the box. So that's wonderful. Now, Annette, let me turn to you about, what system changes are currently happening and what changes are still needed to better, provide treatment for the people in New Hampshire who need it.
So first, let me start off by saying one of the best things that actually ended up happening was the elimination of the X waiver. And that was previously healthcare providers had to obtain a special waiver from the Drug Enforcement Administration before they could prescribe buprenorphine or Suboxone for opioid use disorder. That has really opened up so many different areas for folks to be able to seek MAT services or medication-assisted treatment without those barriers. One of the other things that's really happened really great in the state is there's been a huge expansion of the naloxone, and that is, of course, designed to rapidly reverse the opioid overdose. There have been huge numbers, and obviously through some of the SOAR funds that have gone out through the state and also to different providers or community providers that hadn't anticipated or thought that they needed the naloxone. So that's been fantastic that folks in the community have been open enough to saying, you know what, yes, we're going to learn how to do this and we're going to keep it on hand because you never know. The other thing is, of course, the alcohol fund through the Governor's Commission on Alcohol and Other Drugs has been fully funded, and that did not necessarily happen for quite a few years. So really pushing to ensure that those funds get out to the community has been amazing. And let's not forget also the opioid abatement funds that are currently in the state. And there is a commission set up and scheduled to be able to review and take a look at what's needed in the state. But I do need to talk about some of the changes that are still needed. So right now, we do have an issue with folks who are looking for, let's just say, detox withdrawal from opioids, because this particular population, it does not meet the criteria for medical detox. Therefore, they're falling through the cracks, and that's one of the areas that we continue to look at, because in order for them to be able to go into a medical detox unit, they need to have a medical condition that has to be overseen by 24-hour nursing care. And this is a problem because folks who are withdrawing from opioid use disorder feel like they're going to die. And, you know, the last thing that you want to do is not have those supports in place for this particular population. So that's one area that we're currently working on. I would say another one that needs a little bit more attention, and hopefully this state will be able to do that, is to really get a full picture of what we actually have for providers in the treatment field that are providing services, and coming up with a certification process in order to be able to do that, so that we can ensure clients are going to be getting the care that they deserve without having any of their rights violated. And then I do need to say this, that although things are improving, because New Hampshire went from number 4 for overdoses now down to 23, down to 23. That's great, because we've done a really great job in reducing our overdoses. But what that also means is that we are going to be getting less funds, because we are not at number 4, which of course that was our goal. So we're doing something really well. But we still have these other areas. And so we may be looking at receiving less federal funds to continue to address this, the opioid use disorder.
Well, thank you for highlighting, you know, the incredible things that have already happened, and also shining a light on the changes that still continue to happen. I think this is important. So truly appreciate that. And I hate that we're out of time, because there's so much more that we can get into with the three of you. So before we wrap, you know, let's give one key takeaway that you want our viewers to have from this conversation. Dr. Frew, I'll start with you.
Sure. Yes, I think what I would like for people to take away, whether they're dealing with a substance use disorder themselves, or perhaps have a family member who is living with a substance use disorder, is that effective treatments are available. And in fact, as Annette said, even more available now, the end of the X waiver process. And so people should feel a sense of hope and a sense of optimism that they can find recovery, they can get better. Seeking that out through the doorway, through a primary care physician, can be a good place to start. But just, you know, a sense of hope that recovery is achievable and treatment is available.
And that we're here to help as much as we can. And we'll have a list to all of those resources available at the bottom of this video for our viewers. Annette, let me turn to you.
Recovery is possible. Please reach out for yourself or a family member to get help. And there is always someone willing to assist you with this process. You're not alone.
You're not alone. That's right. And I think what's important that you just said as well is that family can reach out too. Yes. It's important that family know that they can have, that there is support for them to support their loved ones. Laurie, what are your final thoughts?
Well, first of all, I very much appreciate the points that both Julia and Annette have brought up. I think the adverse childhood experience piece is a big deal. Focusing on the trauma, recognizing that, you know, people don't wake up one morning and go, oh, you know, I think I just would love to be an addict. It's such a glamorous life. You know, that there's always a backstory that needs to be explored, and that the substance use is a symptom, you know, of a much deeper problem. And I appreciate Annette and her work at Farnum has been, you know, invaluable I'm a 211 operator too, so I know, how great it is to be able to have these resources at 3 o'clock in the morning when I'm talking to somebody sitting outside a bus station in Nashua, that I can get them into treatment. So I think just that letting people know that there is recovery, that COVID, although it was, it hit us like a sledgehammer. There were a lot of good things that came out of COVID. I think the telehealth piece is a big deal, that we can do a lot of these, meetings and assessments by telehealth. I just think it has opened up a lot of doors. And as Annette said, we have a long way to go. And we're getting to the stigma. We're doing the best we can. But the fact that we work so close with the hospitals, I think our close relationship with Cheshire Medical and the emergency room especially has been a godsend. The fact that they can pick up their phone and call us, and we can pretty much take care of that person who needs help. Because if the window is this big in that moment, that we can get them into treatment has been a blessing. So.
Well, thank you for helping us fight the stigma, and thank you for being on the other end of that call when people are reaching out for help. Dr. Frew, Annette, and Laurie, thank you so much for the three of you for joining me today.
Thank you.
Thank you.
Thank you.
So to view past Heads Up segments and access additional helpful information resources, you can visit the video link at the bottom of this video description. Thank you so much. Take care.